goodness. It could be a very intimate masterclass.
It could be a very small conversation.
That's nice. We can make it intimate. We can make it small. We did have lots of good reactions.
What does it mean?
So, without further ado, I'm absolutely delighted to invite Harry and Anant to come and talk about their brilliant and fascinating work. Over to you two. And this is a small and intimate setting, so let's make it small, intimate, and casual.
Thank you so much, Anastina. Alright, so I'll just start with a brief introduction. I'm Harikeerthan. I trained as a medical graduate from CFC where I grew up in Kerala and Tamil Nadu, and I worked for a few years in clinical medicine, including in northern India. I was unhappy with the kind of disparities I saw and wanted to try to figure out how to fix that. I was working with the government for some time and then got the opportunity to study here at LSE. And since then I've been working at Sangath, mainly building this initiative called iHEAR, which I'll speak more about in a minute. So to start with, I'll speak for around, I think, 15-20 minutes, and then I'll hand over to Anant to speak. So this is photographed from 5 years back, February 2020, my master's cohort, when we went to Geneva on a study trip, and this is a picture from the World Health Organization. And then there were some conversations happening that there is some virus in China, and it may become something big. And then a month later, everything broke loose, and we were introduced to a new software called Zoom. We were thinking, oh, sounds interesting. Now it's become pretty much a household name. And so what I'll be sharing would span across this 5 years from then. But one of the reasons I wanted to show this picture is also because one of my classmates who in this photo passed away a couple of years back, Malik, and because of health-related reasons. So I would like to dedicate this talk at LSE. This is the first time I'm coming back to LSE after my master's. We were good friends, and so I'd like to dedicate this talk to Malik. Malik died not getting the care that he needed while in his country in Africa. And I wonder if he was somewhere else, the same thing might have happened. And those are, I think, some of the inequities in global health that we are quite familiar with that happens between nations, between different racial divides. But there are inequities that happen within our countries as well. So when we finished our trip to Geneva, and then we started thinking about our dissertation, building on some of the work that I had earlier done. I was working with the transgender community in India. And as you know, India had one of the most brutal lockdowns probably in the history of public health emergencies in the world. And nobody was on the same level. It affected different people differently. And when I was speaking to people from the transgender community, a lot of them shared about how the pandemic had hit them, how it affected their crucial access to gender-affirming services, access to their chosen families, being stuck in households which are not accepting of their identity, being forced to live in a gender that they're not comfortable with, exacerbating several mental health difficulties, and the whole health system was now prioritizing COVID. That meant all routine services were being deprioritized. So it was at this time that I finished my master's and then started speaking to Anant at Sangath and looking at how we can work together. So this first picture is the dissertation that I did and which later came out as a paper. So after speaking to Anant, then Anant introduced me to Aksa, who's also a trans woman. And Aksa also spoke about how she had challenges during COVID-19 accessing healthcare because of her trans identity, and that whether can we do something about it. And meanwhile, Anant and others have been working to look at ways we can address different kinds of inequities with the disability community, with the trans and LGBTQIA+ community. And so we decided, okay, let's try to look into this problem at least, the impact of the COVID-19 pandemic, challenges in routine healthcare access, because a lot of work is been happening looking at HIV care and affirming care, but we decided to look at this. And I just finished my master's from LSE, and so we put a proposal together. We decided, as Anant was at Sangath, and Sangath has a history of being a public health research organization. The 27-year-old NGO we thought Sangath could be the host, and we applied for funding. We didn't get the funding. We applied to another funder. We again didn't get the funding. But thankfully, this funder gave us some feedback. So we thought, okay, because we have Aksa in the team and we're doing something really great, we're looking into this problem. But they said, other than Aksa, you're largely a group of cis-het Hindu men. Why do you think you will be able to do this job well? And several such feedback. Although not all of us were cis-het Hindu men. The criticism was fair, and that took us back to the drawing board on figuring out what are we doing wrong and how can we do this differently. And I started reading up a lot about what is participatory work, and that feedback, and from what we've been learning since then, has informed our work since then. We shortly held a consultation in Bhopal with the trans community, asking them that this is a problem. Would you like us to look at studying? While a lot of them were keen on this and shared a lot of challenges, one of them shared that we've been having researchers like you coming to us year after year, looking into different kinds of problems, but nothing is changing on the ground. Frustrations like that. So that really informed our work since then. And what we've been doing is to figure out how we can change the approach that what was Sangath, a traditional research, public health research organization, was so far doing, can do differently from now on. So that started from the team itself, where now most of us in the team are from the LGBTQI+ and or the disability community. We also come from diverse disciplinary backgrounds. And depending on the project that we're working on, we've set up the team in such a way that either the leads or the co-leads are from the communities that we're working with. Each project, we've been setting up community advisory boards from the communities that the project is looking at. This is a community advisory board of a project called Vaccine Equity, where we were looking at vaccine access among the trans, intersex, and disability communities. So the advisory board also had people from these three communities guiding us throughout the research project. In other projects, we've had community workshops, which are not data collection exercises. These are workshops where we sit together to discuss the research design, and we keep going back to them, initially to finalize the research question, then to discuss the research methods. Then when data starts coming in, taking the data back to them, saying, what do you think the data is showing? This is what we are trying, these are the themes that we have generated from this data, but what do you think? And then finally asking them how should we disseminate this data and what can be done next? And so each of our projects have been kind of building on one on top of the other while working along with communities. In addition to that, one of the challenges we were seeing was that in many research studies, let's say it is a survey, you have a bunch of questions and then you go to the community and then ask them to fill. The amount of choice that is there is limited to whatever options are there in your survey. Nobody gets to decide the questions within the survey. So we were looking at how the people from the community can have that power difference can be bridged. And so what we did was using photo voice stories, where people from the community become researchers themselves by collecting data through the medium of photography. This is a photograph taken by Abha. Abha is from Delhi, a woman with locomotor disability, and she says, I quote, if there is a mode of commute, then I'll go to the hospital. If it is not available, then I can't do anything. It was a study looking at experiences of accessing COVID vaccines. And there's a short clip that she shared about her experience study. Let me try.
So when I agreed to take part in this project, I was very much excited that I would be able to create some awareness among persons with disabilities, that how can they advocate for themselves for home-based vaccination. So I agreed to take pictures and send pictures for the project. But while taking pictures, I faced certain challenges because I could not go out myself sometimes, and I had to take help from my family members to take the pictures. But yes, the overall experience was great. I could compile different pictures and tell my own story of taking vaccination and the various kinds of hurdles and the success that I got while getting the home based vaccination. In my district, I was the first one to get home based vaccination. So the whole project was very interesting, and I loved taking part in it. And I hope more of such projects they do come along. And as a person with disability, I would be able to contribute in awareness generation.
So that was Abba who shared her experience of being part of this project called iHEAR Vaccine Equity. And towards the end of the project, we went back to the group of people from the trans and disability communities who were taking photographs, asking them, now how would you like to disseminate this? So they suggested that we do an exhibition and maybe something online as well. Then we set that up. So this was the exhibition that we set up in Delhi, and Naz and Abba and others from our participant group released the booklet, and then we had the exhibition. The Disability Commissioner of Delhi had also come and attended this. And Naz shares this testimonial from the project where they say, I quote, capturing my experience through photographs allowed me to express myself without any limitations. It opened me to my lived experience in a deeper sense. Photo voice stories offered a unique lens into the hardships faced by transgender and disability communities. I believe this method of research allowed for a stronger impact in portraying the lived realities of many, unquote. So this is from Naz, who was a trans non-binary person from Chandigarh who took part in the project. And a lot of people like Abha and Naz, what they were also able to do is, because they themselves took the photos, they were able to share it within their own circles and do advocacy themselves, even outside of the project, towards trying to fix some of these challenges that they were facing. So that's some examples of some of the participatory methods that we've been using. And over time, what we've been doing is experimenting with a lot of that in several projects. And a lot of that is also coming from the people with lived experience from within the team. So this is Bhakti from my team, who's a research assistant, and she was kind enough to record a short clip. So I'll try to play that.
Hello everyone. My name is Bhakti Ghatole. I'm currently working with Hari in Vaccine Equity, and I'm 100% visually impaired. So talking about participatory research, often it is seen that researchers identify the problems and then they themselves come up with the solutions for the community. And this exact notion is challenged by the participatory research, where they emphasize that the researchers need to identify problems by involving the community and collaboratively design solutions for them. So during vaccine equity study, we were also trying to understand vaccine hesitancy, and often trans and disability communities were blamed that they are not coming on the center and taking the vaccination. So it was assumed that there is some kind of hesitancy, some kind of fear within these two groups. But when we interacted with them, we found that there were so many different levels of challenges, including informational, transportational, infrastructural, because of which even if they wanted to, they found it so difficult and challenging to step out of their houses and go and take the vaccination. So it is not possible to unlearn ableism and heteronormativity within one day, and therefore it is important to have continuous dialogue with the community, especially when we are conducting research, when we are planning interventions for them. So somewhere that became possible when we were doing vaccine equity study. We had community members as collaborators, advisory board members. We could also conduct some workshops with them. And then the research process, not just remained about what to ask, but it became also about how to ask and how much to ask. So I feel that nothing about us without us, it should be the lived experience of all our research participants. And if we want to move towards health equity, then we need to have equity in the process itself. Thank you so much.
Take picture. Stop recording video.
All right. I'll stop here and hand over to Anant, but before that, I want to just share a few reflections from this experience so far. So one is that often in global health, we keep thinking about inequities that are at the global level between countries, between races, but there are inequities within our countries, within our own states, within our own communities, and there's a lot of work that is required to look into that and try to fix those inequities, but in a way that doesn't create new kinds of inequities. Second thing I want to share, I think a couple of days the QS rankings had come, and I think LSE is again ranked as one of the top social science institutions. And when I think people like me come from India to an institute like LSE, sometimes what ends up happening is that we then feel like now we're at the top of the world and we have become experts and we know the cutting edge knowledge in the field, and then we're just waiting to go back and share that knowledge and do great work with that, and then we forget that we know very little, and that we know only a certain kind of knowledge, and that there is immense knowledge in the communities that we work with. Maybe that knowledge is not in the form of a paper, maybe that knowledge is not shared in the form of a lecture, but it is knowledge, and maybe people in the communities may not have the language to share that in a language that we may see on a Zoom webinar, but it is important knowledge. And it requires a lot of humility to be open to that and to learn that and to learn from that. And I think so one of the major lessons I think for me is that your learning doesn't stop with a master's or a PhD, doesn't stop within academic institutions, and that most of the learning that has been happening has been from people with lived experience within communities, within my team, and so on. And I think that is extremely important when working on health equity. And finally, what I wanted to share is that as I was walking around the campus today, I was seeing the really beautiful looking glass buildings, and I was thinking about how I miss sitting downstairs in CBG in those really nice tall chairs and working on my laptop. I really miss that because it was helps you be quite productive. But at the same time, I think this is especially to the students that I wanted to say that don't get too used to it, because when you start getting used to environments like that, then when you go back to your home country, then you would also want to continue to be in environments like that, in glass buildings in Delhi or Bombay, which is quite alien and separate from what are the actual lived realities of people who need or who would benefit from the kind of work that you could do. And so what I just wanted to share this advice to the students that don't keep moving from glass buildings to glass buildings and trying to step out of them wherever you are. Thank you.
Thanks, Hari. So, just quickly a little bit about myself. My background is in medicine, ethics, health policy, mental health. I also do some work in health systems, and I've been working with Sangath for the last many years. And part of what Hari described was our quest of trying to figure out how to work in the health equity space. Now, a lot of this work builds on work which Sangath has done historically, because Sangath does a lot of work in mental health, and mental health has the same kind of dilemmas around challenges with stigma, discrimination, lack of access, lived experience perhaps not getting the same kind of importance as specialist expertise, because as you know, global mental health is also largely been driven by psychiatrists and psychologists, and that comes with its own critique. But also the lived experience of many of our core initial founding members, but also as the team has grown, all of them as well. And we've recognized that it is important for that to be the base of the kind of work that we do, and that becomes integral in the way we have then moved forward. So, as Hari described, there's been a fair bit of research we've been doing over the last 4 or 5 years, primarily to try to understand access issues, to understand quality issues, to understand challenges with affirmative care. But what we have then discussed is also it's not just enough to do research, right? Because you can do research and publish in high impact journals, because that is a primary aim for most research teams, because that enables you to share your findings, maybe get more funding, and that the cycle continues, right? But how do you bring about change has been something that we have kept on reflecting on. And part of what we have tried to do is hence design material, and recognizing that our small team has this sweet spot of also having members and collaborators who are themselves health professional educators, is focused on trying to ensure that the future health professionals who are currently being trained and those who are continuing health professional education can be reached out to, so that they are able to understand why this is important and why there is a need to respond to that. And hence designing material, conducting workshops, training medical educators as well as medical students, so that they are able to again think about these issues and respond to them. And part of it is also creating spaces within medical institutions which are supportive. Many health professional education spaces, university spaces, college spaces are still very phobic. They're transphobic, they're queerphobic, they don't have accessibility as a core element. And that keeps away also students who might have these identities. Even though India has quite progressive legislation now, both on the disability side as well as on the Transgender Protections Act, but still that has been a challenge. So part of creating reform is ensuring that we are looking at how these spaces can be made more welcoming, right? And so that's where the training part comes in. So a lot of training again with educators and students to try about bringing about change. Now, of course, part of what you need to do is to create those dialogues, and hence we've been doing a lot of conferences, meetings, where we try to bring together the community and researchers, educators, policymakers, but not making it tokenistic, because I think that's one more challenge that we often see in the kinds of engagements that we have in global health. You will have a community member who is perhaps part of a panel, but that's because you want to show something and be tokenistic about it. So how do you ensure and are very particular about ensuring that community participation is center staged and that they are the ones who hold the stage? You don't take the stage from them, and so that they have an ability, they do already have an ability, but they have an opportunity to be able to share their thoughts, their reflections, and key takeaways. And so a lot of our engagements have focused on that, and of course this is building again on work which has happened in the TB space, the TB survivor networks, in the HIV space, where people living with HIV have had a long history of working with the state, activism with the state, etc. for reform. So meetings with the State AIDS Control Society, at the National Apex Mental Health Institution, the National Human Rights Commission, event we did with UNDP focused on leaving no one behind, as well as a national conference we did on affirmative medical education. So creating these spaces where those kinds of dialogues can happen, while ensuring that to the extent possible, it is also a safe space, so that people can be themselves, first of all, right, and they can express their thoughts and reflections. We, of course, also have to ensure that these findings are available in the public domain. So we do, of course, also write papers because that is an important documentation of the research that we do. We do not shy away from that because that's important. But try to again ensure to the extent possible that this is open access, it's available to communities and to researchers who are working with communities, but also using lay media. So writing for popular newspaper platforms or media platforms, so that this kind of dialogue is something which is accessible to anyone. You don't need to be an academic to understand some of the work which is happening. And again, linking it back often to lived experience, to the voices of communities, and that I think has also helped bring about some level of dialogue as part of the larger change. A strong focus for us has been figuring out how can we ensure that the communities that we work with can be center staged and they can be supported to become researchers, to understand their rights, to do advocacy. So a lot of our projects have hence focused on creating mentoring spaces where community members can be supported in terms of these aspects. So the Transcare Queer Ambassadors project focused on primarily health professional education spaces and working with medical students or health professional students who wanted to create spaces in their own campuses to bring about change, and having again a dyad where they were supported by a faculty member, there was mentoring available. The Peers for Equity project actually also focused on intersectionality, which is a strong element of our work as well, where we had members of the queer community and we had members of the disability community, and they were put through a structured set of courses and then mentored fellowship, where some of the outputs included coming out with their own projects which they wanted to do, but then now with the inputs that they had received or advocacy efforts, etc. And this is part of the longer term change that we think is important, where it should be the communities that are enabled over time and supported so that they can lead their own research projects, they can do their own advocacy. And for groups such as us, we step back over time, perhaps become redundant, if not obsolete. And that I think has been an important element of work for us as well. And this is important again because many community members tend to think that the way research is conducted often is extractive. It has an element of being phobic, and the way they are viewed also is often disrespectful. So this is a testimonial from Shinjini, who speaks about the fact that for the longest time research on trans and neurodivergent people has been done by cisgender and neurotypical people, which has had disastrous consequences for us. So with that in mind, I wanted to use this as the first opportunity to develop a scholarship for us. So this was someone who was a part of one of our structured fellowship projects and had that opportunity. So what do we want to do moving forward? I mean, we are about 4 years old now. In a couple of months, we'll be 4 years old. We want to move towards perhaps thinking of ourselves as a safe space, a center, which has a focus on health equity. Because we are located in central India, where sometimes those spaces are not very easily found. That is something that we are thinking of. We also want to build on the work we've already done with the LGBTQIA plus community, the disability community. In Madhya Pradesh, we have the largest tribal population of India, the Adivasi community, and so that is another community that we hope to start working with when we feel that we are ready in terms of having the representation within our own team, because that's a core element of how we approach work. We do not like to start working with communities till we feel that we have that team representation and understanding, and then bring together various elements of this axis of change which is required, whether that be research, advocacy, capacity strengthening, but also creating spaces where communities can be themselves and can be a part of this kind of structural change. And already in Bhopal, we've tried to do that with events we've done with the communities. We've started to look at potential funding which will enable such a center. As all of you who are from the development sector know, this is always difficult because we are so project dependent that it becomes often driven by funder agendas, it becomes driven by project agendas. It's about the deliverables and the milestones that we have to meet. So just being able to move away from that into actually having time where you can reflect and think and collectively create a space for reflection and learning can be difficult. But hopefully over time we will be able to work on that. And of course, we're very open to feedback and ideas around that. So I think the iHEAR story, which is not a very long story, and I think LSE has had a role to play because Hari trained here, probably got some inputs and training which informed based on his prior experience as well, and has helped contribute along with other colleagues on how we are approaching this story and this thought process and this learning. Has also helped us think about some of our wider work that we do in Sangath. In Sangath, we do a lot of community mental health work. We work a lot with community health workers, ASHAs, as they're called in India. We work a lot with patients with lived experience of mental illnesses. We are also now working in health systems. And so this core philosophy, which iHEAR has often focused about, which is about communities and working with communities in a respectful manner and ensuring that we are not becoming part of the problem, is also informing some of the wider work in terms of how we work with persons with mental illness, how we work with frontline health workers and try to ensure that they are also supported, that their needs are talked about, and that they are given the stage where possible. And we hope that over time, this is something that we keep building on. So I'll stop here, and we're happy to take any questions or comments or reflections that you might.
Thank you both. I'm just going to switch off the recording because I think discussion